I am Dr. Demilade Adedinshewu, and I am an assistant professor of medicine and a non-invasive cardiologist within the Department of Cardiovascular Medicine, and I am based out of Mayo Clinic in Jacksonville, Florida. The title of the article that I'll be discussing today is Rapid Throughput Screening for Asymptomatic COVID-19 Infection with an Electrocardiogram. Short form of the study is called RACE, and this was a prospective observational study. The objective of this study was to evaluate the ability of a neural network to identify SARS-CoV-2 infection using point-of-care ECG obtained with a portable device. By way of background, I should mention that a previous study already demonstrated that using a 12-lead ECG, we can use a neural network to identify the likelihood of COVID-19 infection just using data from the ECG. And this was published a few years ago. Based on that study, we hypothesized that it is possible to identify subtle changes on an ECG that are indicative of COVID-19 infection, but in this case, using a portable ECG. So what we did was we enrolled 2,827 patients in a prospective observational study starting in December of 2020 through June of 2021. And we wanted to determine the accuracy of a point-of-care handheld, smartphone-compatible, artificial intelligence-enabled ECG. And for this ECG, we used a portable handheld device that was developed by a LifeCore Cardia Mobile. In summary, our study participants were 48% male, 79% white, and 7% endorsed prior COVID-19 infection. We found that this point-of-care artificial intelligence ECG algorithm was unable to effectively discriminate between ECGs performed among patients who had COVID-19 infection and those who did not, with an AUC of 0.56. So contrary to the prior 12-lead ECG study, which I mentioned earlier, a point-of-care AI ECG failed to reliably identify asymptomatic COVID-19 infection. This study really emphasizes the importance of validation, prospective testing, as well as ensuring that similar populations are being used when evaluating artificial intelligence models for use in clinical care. Now, I'm just going to talk a little bit about how these findings are important for clinical practice. There's a lot of excitement now about the potential use of artificial intelligence in clinical care. And as we start to review the potential uses of these tools in our practice, we really have to ensure that we thoroughly evaluate these tools by conducting not just retrospective studies, but also prospective studies in the population that they will be used in. This is because it is possible that there are certain conditions during the time of development that might not be met during testing. And this just really provides us with more information about how well this tool will perform. So while this was a negative study, we learned a lot about the potential for using this tool for screening. We learned a lot about how there might be differences in ECGs that are done using a standard 12-lead ECG machine compared to a portable handheld device. And we also learned that it is really important that validation is done with artificial intelligence models before it is ready to be deployed in clinical practice. As the next step for this research, we are hoping to expand the study by enrolling more participants, making sure that we include both outpatients and inpatients, and also consider data collection that would involve multiple leads, not just handheld leads, as well as precordial leads, in seeing whether this is something that could still be of use in screening patients. And finally, I would like to encourage you to review our article in Mayo Clinic Proceedings Digital Health, which is available open access. Thank you.